I'm going to start now with our last section, the endocrinology section, and I'm going to go on to case number 1 here. And this is a 17-year-old girl who comes to the emergency department with lower abdominal pain, increasing weakness and lethargy for about 2 days. Her family has noticed a decreased appetite, nausea, and vomiting. So something that has occurred over the last couple of days. For the last month or so, they have noticed that the patient has been complaining of being thirsty and going to the bathroom to urinate constantly. So it seems something happened over the last couple of days, but a month ago, they noticed that the patient has been going to the bathroom a lot, polyuria, polydipsia. Her temperature is 37.8. Her blood pressure is 100/70. Her pulse is 130. Her respiratory rate is 32 per minute. She is ill-appearing and lethargic. She answers questions with difficulty but appropriately. Her physical examination shows dry oral mucosa and a supple neck, no jugular venous distension, equally round and reactive pupils, and clear lungs. Her heart has a regular rhythm and is tachycardic. Her abdomen is tender on deep palpitation. And the most important thing in the exam of this patient is that the neurologic examination shows no obvious focal deficits. Now, this is important because a focal deficit in this patient would make you think of something in the central nervous system, some space-occupying lesion, whether it's a tumor or a stroke syndrome. So this patient being lethargic and having no focal deficits, then you think about other things that would do that without causing a focal deficit. And the mnemonic that I always like to remember is drugs, DIM, that's the word, D-I-M, DIM, drugs, infectious processes like encephalitis, meningoencephalitis, and metabolic causes, hyponatremia, sugar, diabetic ketoacidosis, hyperosmolar hypoglycemia, calcium, and uremia. So that's the thing as you think about this patient, unless she's got a focal deficit, the first thing that you do is look for one of these 3 causes, rather than going quickly off straight to a CAT scan. A focal deficit means CAT scan. A non-focal deficit means looking for one of these things. So your protocol in patients with altered mental status and confusion should look like this. If the patient has focal neurologic deficits, if this is so, then you should look for some space-occupying lesion, a bleed in the brain, a tumor in the brain. We've seen this commonly with toxoplasmosis in patients with HIV. But the bottom line here is you should evaluate this patient with a CAT scan. If there are no focal deficits, like our patient here, then consider our differential drugs. So you should look for, check a tox screen. You should look for infections like meningoencephalitis. So something like an LP would be the right thing to do in this patient, and to look for electrolyte abnormalities. Would be another thing with a chemistry profile. We said that hyponatremia, glucose disorders do this, calcium, and uremia. So this is a good mnemonic to remember, especially because this is in order of frequency. So drugs are the most common things to do that. Infections are the second most common, and metabolic causes are the third. The initial diagnostic plan should focus on what we just said. So this is why they're looking at a basic metabolic panel initially, a complete blood count that would look for some kind of infection or would point to some kind of infection, a urine analysis that would again look for some kind of infection, and doing a lumbar puncture and a tox screen. So in this patient, the toxicology screen is negative. The lumbar puncture shows no pleocytosis, 0 white cells. You're safe there, nothing to worry about. The urine analysis shows pyuria, 60 white cells, and ketones. So now you're thinking, well, not only does she have a urinary tract infection, maybe she's got diabetic ketoacidosis. Maybe this is the reason why she was 1 month before this, she had polyuria, polydipsia. You look at the complete blood count, this looks good, but you look at the sodium and all the other stuff here, and look at this. You're looking at the chemistry profile, and you find that the sodium is 130, the potassium is 6.5, the chloride here is 100, the bicarbonate is 8, and the creatinine is 65 and 2.5, and your glucose now is 580. So this is your glucose, this is the BUN and creatinine, this is your bicarb, this is your chloride, sodium, and potassium. So there's a couple of abnormalities here. One is the glucose is very high. So this, along with the ketones in the urine that they just told us, makes it almost definitive that this patient likely has a diabetic ketoacidosis. How do I know she's got a ketoacidosis? Because look at the bicarb. The normal bicarb should be 22. It is decreased in this patient. And in fact, if we do the anion gap, we calculate the anion gap in this patient, 130 minus 100 plus 8 gives us an anion gap of 22. In most anion gaps, you don't have to put the potassium in there. It's the sodium minus the sum of the chloride and the bicarbonate. And a normal anion gap is less than 12 when you do this. This patient definitely has a high anion gap acidosis. Now, you would have to see the ABG to document acidemia, but this is likely what's going on. Be careful, because not all elevated anion gaps mean diabetic ketoacidosis. There's other things that cause this. Other causes of an elevated anion gap is lactic acidosis, salicylate poisoning, methanol and ethylene glycol poisoning, and uremia. There's some other ones, but these are the basic ones. In this case, we're thinking about diabetic ketoacidosis because there's two more factors here. One is the elevated glucose and the urine showing us the ketones. So we're almost positive that this patient has a diabetic ketoacidosis. So, well, what do you do in this patient? The answer to this is this patient needs admission. And in most places in the United States, it really means admitting this patient to an intensive care unit. So they don't go to the normal floors. There are places where if the patient is pretty stable and has a very mild diabetic ketoacidosis, they could go to the regular ward floors, but they usually get admitted to the intensive care units. So that's your first step here. Admit the patient, usually to a monitored bed. This person, over the next 24 to 48 hours, will need close monitoring of the electrolytes. So it's very important that you have them in a place where they can monitor things really close. The second thing is, what is the most important thing in this patient? What is the most important thing? Just like we talked about in asthma. What's the first thing that an asthmatic patient with an exacerbation will need? Bronchodilators. What's the first thing that a patient with diabetic ketoacidosis will need? Remember, diabetic ketoacidosis doesn't occur in type 2 diabetes. These people have type 1 diabetes by definition for your purpose. So it means that this patient has insulin deficiency. So IV insulin is the cornerstone of treatment for this patient. That's the first thing. And along with this, it means giving back the patient the fluids. Most people that come in diabetic ketoacidosis are at least 3 to 4 liters down. They're at least dehydrated 3 to 4 liters, so this patient will get IV fluids. When we give back IV fluids, except a couple of exceptions, one of them are the burn patients that we give back Ringer's lactate and some other stuff. But most patients, 99% of the patients on the boards that we give back fluids, it's usually 0.9 normal saline. Normal saline. 0.9 normal saline. Everybody gets that. So when you give this patient back insulin, they also need fluids. What's the most important thing? Well, the most important thing is insulin, because you can't survive without insulin. This patient, by definition, has type 1 insulin-dependent diabetes. They're without insulin. They need insulin. You could give them all the water you want. You're not going to reverse this unless you give them insulin. The fourth thing in this patient is to look at some other stuff that's going on. And let's go, this is important, especially for clinical practice and for the boards. Number one, you notice that this patient's potassium is elevated. Now, is this normal for this patient to have this? The answer is yes. It's normal for this patient to have hyperkalemia. There's two reasons for this patient's hyperkalemia. One is the lack of insulin. Number two is the acidemia. If you did an ABG on this patient, I don't know if they did, I don't think they did it in this patient, but it would look something like this. That's what it would look. So this patient would have an acidemia, less than 7.4. The CO2 is decreased to try to compensate for the metabolic acidosis. So they become a little bit alkalemic. They try to blow off CO2. This acidemia and the lack of insulin drives potassium out of the cells into the periphery. So in a way, this person is really not hyperkalemic. You don't have to worry about this hyperkalemia as long as you treat the patient quickly for the lack of insulin and the diabetic ketoacidosis. This is the norm. This patient should have a high potassium. If they don't have a high potassium, what this means, let's say we took a patient like this. Let's say this patient, they gave us, instead of a high potassium, they gave us a little bit on the lower side of normal. They gave us a potassium of 3.5. What does this mean? Well, it's normal. No, it's not. This patient's potassium, given the situation, should be high. So if this is normal, what does it mean? This patient has severe potassium depletion. You're in trouble with this person. So, this is a commonly tested scenario, and it's a common scenario we see in clinical practice. If the patient has diabetic ketoacidosis, the norm is to have a high potassium. This will redistribute itself once you treat the patient with fluids and insulin. Once you relieve the acidemia, this goes away. You don't have to worry about it. If the patient has a normal potassium or even a low potassium, you're in trouble. This means that this patient has potassium depletion. So, what do you do with this patient? If potassium is normal, it wasn't in this patient, so we're okay, give potassium in the fluids from the beginning. Please look for this all the time. This is a commonly missed point. So everybody okay there? So look at the potassium right away. If it's high, you're okay. You're gonna be okay. If it doesn't, if it's not, you're in trouble. You got to give potassium in the fluids. You can't give potassium that quickly. That's the problem. You give about 10 milliequivalents about an hour. So you give 40 over 4 hours or something like that. You can't give it too quickly. Okay? The second thing is this. This patient has an elevated BUN creatinine. What is the likely diagnosis? What is the likely reason for this? It's pre-renal azotemia. How do I know that? I don't know it. You're going to see that reverse with the fluids. But the natural history of type 1 diabetes means what? That this has only occurred, you could only have type 1 diabetes maybe a couple of months. So this patient should not have renal disease from the diabetes. So this should be pre-renal azotemia. I also look at the ratio. And if the ratio of BUN to creatinine is over 20:1, then it's likely pre-renal azotemia. So I'm probably okay with that. Giving the fluids back to the patient would probably relieve this. So we're okay with that. The third thing is that this patient has a mild hyponatremia. Is this consistent with the high glucose? Yes. This is called pseudohyponatremia. So this is consistent. As the sugar goes up, the sodium goes down. It's because now you got more sugar in the amount that you measure. So the amount of sodium goes down. It's a relative thing. The more the sugar goes up, if it's 1,000, 1,500, like we see in type 2 hyperosmolar hyperglycemia, then the sodium goes down and down. It's not really down. It's the way you measure it. When you put this in a tube, patient's blood in a tube, if the sugar is 500, well, this patient, this much, is glucose. But you measure sodium in this whole tube, right? So you're measuring this whole thing. That's why it's relative. It's not really low. It's because a lot of this compartment has been taken up by the elevated glucose. So this relationship you should know about. As the sugar goes up, the sodium goes down here. More higher sugar, the likely the sodium will be even lower. It is pseudo-hyponatremia. It's not for real. Okay? Once you correct the sugar, the sodium will be back to normal. Good. The sixth thing that's very important in this patient, just like asthma and some other diseases, you have to look for a precipitating cause. A precipitating cause. What are things that stress diabetic patients in order for them to present with diabetes? The most common one is infections. Do we have any evidence of infection in this patient? Sure we do. She's got pyuria. Two of the most common infections that cause precipitation of diabetes. One is urosepsis, urinary tract infection. The other one are pneumonias. So you should look for both of those. In this patient, we already have our answer. She's got pyuria. That patient likely has a urinary tract infection. The most common one in these people is either E. coli, or if you don't find gram-negative rods in the urine, then Staph saprophyticus is another one that is seen in young women. E. coli is the most common altogether, gram-negative infections. So you should definitely treat her for that. That is what likely precipitated her disease. Now, why do infections precipitate diabetes? Well, they cause stress. Stress causes cortisol and the counter-regulatory hormones to be secreted. So now your insulin requirements become higher and higher, and these people are not able to compensate for that. Now, when this patient gets admitted, we said you're going to put the patient on IV insulin and IV fluids, and that's the treatment. About 12 hours later, you're going to see this. You're going to get called by the nurse, and she's going to tell you that the patient's doing really well. The potassium is almost back to normal, right? So it's 5.2 now. The BUN creatinine is almost back to normal now. And the sugar, because you're giving the patient insulin, that this is 12 hours later, into the hospital course, you're giving the patient now a lot of insulin and glucose. You're giving the patient a lot of insulin and water. Well, look at the sugar now. Now it's 180. Now it's 180. But if you look at the bicarb, it has improved, but still, what do you notice here? That there's still an anion gap and there's still acidemia. And you know that because the bicarb is still less than 22, and if you measure the anion gap, look at that, 140 minus 100 plus 12, right? You still have a significant anion gap. And you probably still find ketones in the urine and the blood. So the sugar is low. What do you do with the insulin now? If you continue the insulin, this sugar will go 180, 120, 80, and the next thing you know, a patient will probably be in a coma because of the hypoglycemia now. So you can't continue the insulin unless you give the patient some sugar on top. Now, how come you don't discontinue the insulin? Because diabetic ketoacidosis is not so much about high sugars. And if you notice that the patient's original glucose was 580, sometimes in patients with diabetic ketoacidosis, it's not even 580. It's 500. It's 400, 450. That's the classic type of glucose elevation that you get in diabetic ketoacidosis. So it's not about sugar so much, but it's more people in diabetic ketoacidosis where they run into problems is because they're unable to put sugar into the cells and use it as fuel. So what do they use fuel instead? They break down fatty acids, they break down lipids, and that's how you generate the acidemia. That's what kills the patient, the acidemia. So you have to resolve this acidemia. If this patient is going to be safe and will do well, you have to resolve the acidemia in this patient. And what do? To do that, you got to keep the patient on insulin. Even when the glucose drops, how do you take care of the low glucose? You give the patient glucose in the fluid. So now switching over to half normal saline, right? Or putting some dextrose in there is okay. In the IV fluids. Half normal saline. So you keep the glucose at 180, 200, 250, and you continue the insulin to improve the metabolic acidemia. That's your goal. Your goal here in these patients is to improve the acidemia. You have done nothing for the diabetic ketoacidotic patient unless you could resolve this. It is also what you follow in this patient. You don't follow the sugar. That's not going to tell you the patient's doing okay. You don't follow the ketones. The ketones could be positive for days and days later. What do you follow? You follow the anion gap and the bicarb. Both of these are relevant to each other. If the bicarb goes up and normalizes, the anion gap goes down and normalizes also. When can you discontinue the IV insulin? When the anion gap is normal, less than 12, and the bicarb is normal. This patient is out of acidemia. You can discontinue insulin. And now just give the patient what? What is the treatment of type 1 diabetes? They get insulin, but not IV insulin, right? Now you could put them on a standard dose of insulin. Standard dose of insulin, daily insulin. That usually is, you give them some insulin in the morning and some insulin at night. They get some short-acting insulin in the morning and some short-acting insulin at night. Some longer-acting insulin in the morning, some longer-acting insulin at night. You're trying to cover the whole day this way. So you see regimens like regular insulin in the morning, X amount of units, and some NPH or Lantus, or semi-Lantus, whatever. But this is short-acting, and this is longer acting. This will act in about 2 to 4 hours. This will take about 8 hours to start working. Peak. I don't mean to start working, I mean peak, when it has peak action, about 8 hours later. And you give the patient some regular and NPH at night. That's the way you do it. Now, how do you get this standard dose? There is really no formula. Nobody's ever done studies on this because it changes. It will change on the requirement that your patient has. So this standard dose will be based on how much insulin you used in this patient the last 24 hours. You usually take about 2/3 of the total amount that you used up in this patient in the last 24 hours. So let's say you had to use 100 units of IV insulin in her the last 24 hours. Take 2/3 of that. 2/3 of the total. How much did you give in the morning? 2/3 of this. Now, 2/3 of that. You give 2/3 of this thing here, and 1/3 you give at night. And you give about 2/3 of NPH in the morning, and 1/3 of regular, and about the same thing at night. This has no magic to it. This is random. And it changes. It will change really quick. I'm just giving you an idea of where people get the standard dose of insulin. This changes quickly. But it's more important for you to know that the patient needs to be covered over 24 hours. Type 1 diabetes only gets treated with insulin. They need some regular and some NPH. They need some regular at night and some NPH at night to cover throughout the whole day. So this patient will get discharged on a regimen like this. They will come to your clinic about a week later. Discharged home. And follow up in clinic. Let's say about a week later or so. Okay? So what's your goal here? Why do you want to see this patient back 1 week later? Well, you want to fix these insulins, right? You want to make sure that this patient is getting good glycemic control. What's good glycemic control? What's a normal sugar? You want the glucose, the fasting glucose, less than 126. That's the definition of diabetes. A fasting glucose above 126 2 times means the patient has diabetes. So if you're going to control this patient, then you need to get them to this level. So 1 week later, when the patient comes to you, what should they have? They should be able to check their sugars at home, fasting, and give you a summary of their glucose throughout the day. So let's say this patient tells you at 12 o'clock at noontime, her sugar runs 250. This is the glucose, 250, just before she eats lunch. This is too much, right? It's more than 126. So you have to adjust her dose. What will affect, which ones of the 4 insulins will affect mostly the glucose about noontime? The regular insulin, right? This has a peak at about 4 hours, 3, 4 hours, 2 hours, but this will affect mostly the noon glucose. People take this in the morning about 7, 8 o'clock, so it's going to peak about 12 o'clock, 11 o'clock, and so forth. So if you want to adjust this, your action here would be to increase the regular in the morning. That's your goal here. If, on the other hand, she tells you, look, you know, at 6 p.m., just before my dinner, I check my sugar, and now it's 220. That's high also. Which one do you adjust now? You go back and you say, this, the regular, works about 4 hours later, right? The NPH takes about 8, 10, maybe 12 hours later sometimes. So the NPH is the one that affects the sugar in the afternoon. That's the one that I'm going to up until I get it back to normal. What's normal? Less than 126. That's your goal. You usually increase it by 2-3 units per time, maybe 5 units per time, depending on how high the sugar is. You don't want to do too much. You don't want to cause hypoglycemia. That's more important not to do that than hyperglycemia. So this is easy to remember. You have to know the effect of the insulins, the types of insulins. These are the ones that are mostly used. Those are the ones you need to know about. There's one exception to this rule, and this is a patient presenting with morning hyperglycemia. Morning hyperglycemia. Morning hyperglycemia poses a specific issue. It may be because you're not giving the patient enough insulin at night. Now, when do you give the NPH at night? You give it about 6, 7 o'clock, depending on when the patient eats or so. So if you think about it, if you give NPH about 6 o'clock, right, that's way later. The patient hasn't received anything at night, right, 12 hours later, hasn't done any exercise or so, wakes up in the morning, right, and the 7 o'clock in the morning, the glucose now is up because the NPH insulin now has tapered off in effect. Right? So the sugar bumps up. And this is called the dawn effect. The dawn effect means that in the morning, the insulin is not up to par. It's not good enough. You don't have enough levels. And it's usually because you gave it 12 hours, 13 hours before. So what do you have to do? You have to either increase the NPH or you have to give the NPH later at night. You may do this. Split the regular and NPH in the PM. So for example, give regular before dinner at 6 p.m. and then give the NPH before bedtime at 11 p.m. This way, it's going to have a longer effect in the morning time. Either one works. Most people like splitting the regular and NPH. The problem with the patient is, though, they don't like to take 3 shots now. You got to take 1 in the morning, right, a combination of the 2, and then 1 at the afternoon, and then 1 at night. So now you're taking 3 shots. Nobody likes that. So that's one way to take care of this dawn effect. This is a common problem. The problem, though, is it gets complicated because the dawn effect is really not a syndrome that's really going to kill the patient. This is not going to do anything to the patient. There's this effect, though, or the syndrome, called the Somogyi phenomenon. The Somogyi phenomenon means that this is not true hyperglycemia. it means that this is rebound hyperglycemia. It really means that you're giving the patient too much insulin. The patient is getting overdosed with insulin. It happens sometimes. We don't mean to do it, but it happens. We give the patient too much insulin. What happens is this. If you give too much, let's say NPH, insulin, 2 o'clock in the morning, the glucose is 50. 3 o'clock in the morning, the glucose is maybe 40 now. The patient is in trouble. Maybe it even occurs at 1 o'clock. The patient doesn't remember this, though. They're sleeping. In fact, sometimes they tell you, though, that they have nightmares. They don't sleep well. So that's an important sign to look for in the history. You ask the patient, did you sleep well at night? Do you sleep well at night? Tells you, no, I haven't slept in a long time well. I get these nightmares. I wake up and I go back to sleep and so forth. Maybe because the patient really is having hypoglycemia. Well, one or two things are going to happen to this patient. Either they're going to go into a coma because of the hypoglycemia, or you get the counter-regulatory hormones, these important hormones that counter-regulate the effect of glucose and insulin and raise glucose in the body. They increase it. So, you have cortisol here, you have growth hormone here, and all these other counter-regulatory hormones, glucagon. So what do you think happens now to the glucose? Because of the counter-regulatory hormones, well, what happens to it, it starts to come back up to normal now because these hormones are especially made for hypoglycemic events. They save the patient. So now it goes back to 100, maybe 120. When the patient wakes up 7 o'clock in the morning to check their sugar, right, what happens is the effect of the NPH has worn away. 12 hours later. So there's no NPH effect. But there are counter-regulatory hormones here. So what do you think happens? The sugar goes from 120 to 200 to 250 because at 7 a.m. there's no NPH effect. But you got a lot of cortisol. You got a lot of growth hormone. You got a lot of glucagon, etc., etc. So now you get this rebound effect. Boom, your sugar rises. It goes to 250. The patient doesn't know what happened during the night. They don't know. All they do is they see the sugar in the morning, 250. If you make the mistake to assume that this is the problem, the dawn effect, and you give the patient, you increase the NPH, you're going to put this patient who has the Somogy effect into a coma. So always with morning hyperglycemia, always with morning hyperglycemia, decrease the NPH at night until you sort it out. Because you always fear the Somogy effect. That's the one that's going to kill the patient. So please be careful about that. Now, how are you going to really know if it's the Somogy effect or the dawn effect? Well, if you decrease the NPH, well, what's going to happen? If it's the dawn effect, the sugar's going to run even higher now. Okay, so well, you realize that. If it's the Somogy effect, right, what's going to happen here? Now it's going to normalize. So that's a clue. So, but you always, always decrease the NPH at night. Always decrease that. One other thing that some people will do is they'll make the patient wake up a couple times in the morning time, 2, 3 o'clock in the morning, and check their sugars. See, is it low? Is it high? What is it? So one of those two things should give you enough information of what to ultimately do in this patient. But the first thing you do is you always, always decrease the NPH at night. to make sure you don't cause hypoglycemia in this patient with the Somogyi effect. This is a much more important phenomenon, the Somogyi effect, than the dawn effect, because you're going to kill the patient if you increase the NPH. So that's the Somogyi effect and the dawn effect. These are very important clinical points to remember. The third thing is that sometimes in these patients we see something else. We see the patient coming in a couple weeks, 3-4 weeks later. 3-4 weeks later, we see that the patient tells us now that they have no reason for insulin. Their sugars are controlled without any insulin. They tell you, I take the insulin that you gave me and my sugar drops down. So I stopped it. And now I check my sugar at home and my sugar is always normal. What's normal? Less than 126. So this patient has the honeymoon period. Honeymoon period means that this patient has residual pancreatic mass. Residual pancreatic mass. So they still have some insulin secretion. That's good. That's very good because you won't have to do much to this patient and they can control themselves. What happens with the honeymoon period is this. If you look at the percent of the pancreatic mass, and in a patient with diabetes, and you look at it over time, the theory behind type 1 diabetes is that these people get some kind of infection, maybe Coxsackie infection. It causes an inflammatory process of the beta cells. This is called an insulinitis. What happens after you get the inflammatory process of the beta cells, the insulinitis? Eventually, there's fibrosis and destruction of the beta cells. And this patient will eventually develop diabetes. But that occurs over time. That occurs over time. You look at pancreatic mass and it looks like this. And at some point or another, months later, maybe years later, the pancreatic mass under this point, this threshold is the clinical threshold for when a patient has clinical diabetes. If they have pancreatic mass below this point, they develop clinical diabetes, type 1. It means that below this threshold, they don't have enough pancreatic mass to deliver insulin for daily requirements. If they're up here, they have diabetes, but you don't know about it. If they're here, they have diabetes, but they're able to compensate. It's only when they fall under here that their residual is so low, they can't compensate. You've got to give them insulin. And you may see later that the insulin requirements increase. Now, what happens to some patients, like our patient here, is they're here. She was right here at this point. She got an infection. We said that the infections cause more need for insulin. This patient couldn't compensate. If she was up here, it would be okay, but she was down here. So she doesn't have a lot of pancreatic mass, and especially not enough for an infection. When you get all this cortisol, glucagon, growth hormone secreted because of the stress. So she kind of dipped down here, went down to here to the clinical threshold. And she came into you with clinical diabetes, with diabetic ketoacidosis. Now you treated her, you gave her insulin, you treated her infection, you sent her home and she was doing fine, so she reversed back to here. Well, look at this. She still has some way to go. So this is the honeymoon period. It usually occurs when something of stress increases the needs for insulin in diabetic patients and they develop diabetes before they would have. So when you treat that, they feel okay, they do well after that. You don't need insulin for some time. They will eventually develop clinical diabetes. You can't save them. This period is important because we give now to these patients low doses of insulin. In a way, you're trying to protect this pancreatic mass here. The more you stress this mass, the more quickly you're going to dip into this clinical diabetic part. The less you stress it, maybe you'll do something like this if you give the patient some insulin. They won't be stressed and they will do something like this. It will take them a longer time to develop diabetes because you won't stress the beta cells. Now that's important because the longer it takes for them to develop clinical diabetes, the shorter time, the longer time they have until developing the side effects of diabetes, right? Like the neuropathy, the nephropathy, and so forth. So the honeymoon period now is treated with low doses of insulin. Not to the point where you make the patient hypoglycemic. Low doses, so they don't have to secrete a lot of their basal insulin. Okay? So that's the honeymoon period. That is another important thing. I want to go back to the history here and make sure that we're doing all the stuff here that they did. We talked about in the next page what is your next step, and we talked about changing the fluids from half normal saline because this patient had hypoglycemia. And we talked about the honeymoon period, that she informed you that she didn't need any more insulin and so forth, and what to do there. Now, I want to talk a little bit about, before we go into the next case, about type 1 diabetes. Now, what makes type 1 diabetes different than type 2? One is the insulin. Patients with type 1 diabetes have no insulin. We talked about the pathophysiology behind this, maybe of viral infections in susceptible individuals, and this, the cause of an insulinitis and destruction of the beta cells. But the bottom line is, people with type 1 diabetes have no insulin. Type 1, low insulin. These people are usually young patients, really young sometimes, in their 20s sometimes, and so forth. They're usually young. They're lean. They're not obese. They don't have other comorbid conditions, at least in the beginning, because they're young. There's not so much of a familial pattern. Not so much. When we talk about families having diabetes and the risk of diabetes, we usually talk about type 2 diabetes. If you take identical twins, one has type 1 diabetes, the other one has 50% chance of developing type 1 diabetes. That's not a lot in identical twins. In type 2 diabetes, if one patient has type 2 diabetes, their identical twin has 100% chance of developing type 2 diabetes. So the familial stuff, right, and from parent to child and so forth, siblings, usually occurs for type 2 diabetes. People with type 1 develop diabetic ketoacidosis. They don't develop anything else when they have the side effects. The last thing that I'm going to say here is, if you think about our patient, we talked about this, how long has she had this disease for? Maybe weeks, maybe months. So when you talk about complications, you have to talk about late complications. Late complications. So in type 1 diabetes, once the patient gets diagnosed, from the time they're diagnosed, you don't have to worry about retinopathy. You don't have to worry about nephropathy. You don't have to worry about neuropathy. So you don't do testing for those. it takes at least 5 years for a patient with type 1 diabetes to develop some kind of complication because they haven't had the diabetes for a long time. So late complications, consider after 5 years, right, to be evaluated by ophthalmology. Consider after 5 years to look for protein in the urine. You should not be doing these tests early on. If they ask you which is less likely to be done in a type 1 diabetic early on, these are the tests that this patient shouldn't have any neuropathy, shouldn't have any nephropathy, shouldn't have any ophthalmopathy. Okay? It's only after 5 years. When do we send to the eye doctor? After 5 years. When do we check for protein in the urine so we could use an ACE inhibitor? After 5 years. Okay? Very good. Good. So, everybody okay with that? Let's go on to case number 2 really quick. This patient is a 28-year-old man with insulin-dependent diabetes mellitus type 1s since age 12, has been on the same dose of insulin, 22 mph and 18 regular in the morning and 18 mph and 8 regular in the evening, both before meals. For the last 8 months, he started a new exercise program a week ago when he joined the health club as part of his company's health promotion program. He goes to the health club around 5:30. Since starting the exercise program, he has noticed symptoms of hypoglycemia, namely headaches, tremors, diaphoresis, and palpitations. So these are symptoms of hypoglycemia. Hypoglycemia is defined as symptoms consistent with hypoglycemia and the low sugar. And the symptoms go away once you give the patient sugar or orange juice or something alike. So home glucose monitoring results for the last few days are in the morning 112, 104, 98, 103. This is good. Noon, a little bit lower. PM in the 40s, 35s, and so forth. So something is going on in this patient. All of a sudden, he was controlled before. This is a 28-year-old guy and has been having diabetes for a long time. So one of the things you think about is maybe renal failure. If you develop renal failure, now maybe your insulin has a longer half-life. So with new onset hypoglycemia, in the diabetic patient, one thing you got to think about is renal failure. That's the first thing. You got to rule that out, especially in this patient that has had this diabetes for a long time. If he hadn't had it for a long time, you don't have to worry about it because we said they don't get the complications. The second thing that you need to think about is if you go back to this patient's history, you'll notice that this patient started exercising all of a sudden in the afternoon before dinner time. Now, we always tell diabetic patients to exercise. Why? Because it's really the only way you could put glucose into the muscle without insulin. So it's always great for diabetic patients. It's one of the things we always tell them to do. So maybe the new exercise program did it. So you got too much insulin on board given the exercise that this patient is doing. So what do you do in this patient? Well, you make sure you check the BUN and creatinine, and you find that this is normal. And then the only thing you do after that is you tell the patient, of course, to continue exercising. What do? You adjust the insulin appropriately. What insulin would we have to decrease to affect the glucose in the afternoon? The NPH in the morning. So remember, he's going about 5, 6 o'clock, right? So the NPH in the morning would have to be decreased 3, 4, 5 units. Let the patient exercise. He'll be fine. Okay? So I'm going to stop right there, and we'll take a break and come back and continue with case number 3.